This video was made possible with the support of our Patreon members. Welcome and thank you for tuning in to Psychology Is. I'm excited today to introduce you to Dr. Jennifer Giordano, who is a psychiatrist in private practice based in Michigan with a very interesting story and many interesting perspectives on the field of psychiatry and of mental health. So welcome, Jennifer. Thank you for joining me.
Thank you so much for having me. I appreciate it.
I was listening to different interviews with you, and all of them are great. You've really sat with some excellent interviewers, and you've been very open about your own experience, your journey, both on a personal level with your own mental, emotional well-being, as well as professionally. And I was thinking a lot about, what do I really want to know about you? What about your story do I want to focus on? And what do I think our audience would be very interested to know? So I think the answer to that is many things, perhaps everything that you're willing to share. But within the time constraints we have, I'll focus first on your professional journey. I find it so interesting and admirable when people are able to question their own beliefs and their own paradigm, their own understanding of things. I know you've worked closely with Dr. Kendra Campbell when you were with Free Range Psychiatry. She's been a guest on this podcast, and she's another example of a person who has the capacity to change her mind. So I'd love to begin with you talking about your experience in medical school and psychiatry residency. Where'd you go to school? What was that experience like?
Yeah, sure. I went to medical school at Michigan State University's College of Osteopathic Medicine. Then I did a year rotating internship at Garden City Hospital. And then I did a full psychiatry residency at Henry Ford Health System. So I've been Michigan based
Mm.
my whole life.
And I don't think many people really know what a psychiatry residency or even medical school for that matter entails. So let's start with the residency. What does that look like? What are you learning? What are you doing during a residency?
Yeah, so traditionally in the first 2 years, you're rotating around to different specialties. So there's a certain number of general specialties you have to have exposure to before you then start to focus in and concentrate on psychiatry. So you go through things like emergency medicine, surgery, family medicine, internal medicine, OB-GYN. You go through a smattering of the various specialties. And then usually once you reach your second or third year, you start honing in on psychiatry only. And it entails a lot. It entails it's the full immersion into, the American medical system as a trainee, as a apprenticeship type of a model, along with, testing along the way for, in various rotations and standardized board testing. It's intense. I was during my rotating internship year, I think the maximum we could be on for a shift was 30 hours. So it was dealing with, and that was actually after some regulations had been put in place. So that was better than what like my predecessors had experienced.
Wow.
So yeah, it's full on total immersion, drinking from the fire hose kind of experience for a person going through that.
Mm. And what kinds of settings are you working in?
Hospitals and clinics.
Hmm.
So
And at that point, how, like, upon entering residency, how familiar are, psychiatry students with the diagnostic and statistical manual?
upon entering residency,
Hmm.
definitely not as familiar as they are when they exit. So yeah, that's essentially, it's the Psychiatric Diagnostic Foundation is
Right.
the DSM. Mhm.
And, I guess I wanna deepen my understanding of how it is that the vast majority of psychiatrists upon graduating have such a clear default mode of practice. And I've heard you talk about this on other interviews and how part of it is the general system of healthcare can really limit the amount of time that a medical doctor of any kind or a psychiatrist can spend with an individual. But aside from that, those systemic factors, um, are you really learning in residency that the the default treatment for these various disorders is prescription drugs?
If I had to quantify it for my experience of, and my recollection of it, it was probably, 90% prescription-based education, maybe 10, I think it'd be generous to say 15%. I'd say I would say more accurately 90% of what the focus is on is chemical intervention is the answer. There's not talk about diet, exercise, looking at people's relationships and kind of looking at the whole context of the human experience, which is complicated. It's very much just distilled down to here's our modality, it's medication, and that's the answer. And if that medication isn't the answer, then the next one will be, or the next one, and keep adding, changing, altering medication regimens until symptoms, relent or abate.
Mm,
That's the model. We had some training in, a broad overarching look at therapy modalities, but it's definitely, um, it's short compared to the time we spend and the units are in clinic. Um, it's very heavily medication based.
mhm. So you go through that. Well, the one more question I was going to ask about the training itself is, did you find in your experience that there was a lot of critical questioning or challenging of that primary mode of treatment? Like were students really pressing the supervisors and the mentors and the professors on why these prescriptions seem to be the answer all the time and exactly what neurological abnormalities they are supposedly intervening upon?
Mm. At that stage of a person's education and kind of arc through the process of becoming a psychiatrist, you're so much in absorption mode. And you've been, I mean, the whole training itself is almost a decade. So it starts kind of, in medical school. It's absorb the information, regurgitate, I mean, that's the, which is traditional schooling methods, really.
Mhm,
And so, um, similarly in residency, you're trying to absorb so much. Um, and if and you're trying to do well and you're trying to pass, you're trying to get through the training. And there's I think there's such an in that mode. I think you're not I personally just didn't feel so empowered to push back or
mhm,
ask or wonder. It
mhm.
was more like, okay, let me just try to absorb the information and then
Yeah.
then follow the follow the rules or follow the prescribed, or the taught lesson.
Mhm.
Consideration, questioning, why exactly are we doing this? I had those questions, certainly. I don't thi it's I would imagine it's hard to go through a psychiatry residency and look around and not start asking yourself some questions of like, "Wait, what are we doing? Why are we doing that? What's the rationale? What's the scientific, logical reasoning behind choices of medications, and how is this working?" And yeah, I would say it's not so much that model. I'm sure if someone had, wants to push back on that, it's just I think it's not set up so
Yeah,
well for that. Kind of a
right.
lot of the wondering and questioning. For me, that came definitely after residency. During residency, I looked at things and I went, "Wow, this is really interesting."
Well, um,
Because I was definitely holistically minded from,
mhm.
my
Even at that
early
point.
yeah, my early life. As a teenager, I started being interested in how can we as human beings help ourselves through,
Yeah.
psychology
True.
or things like that. And then it evolved for me. I became more interested in what can we do for ourselves through diet? What can we do for ourselves through supplements, supplementation, all of those things, which don't, typically have a space in our traditional medical system in any specialty. And that's kind of the nature of the overarching system when it comes to medicine. And I think in our society, people will think, okay, I have something wrong. Where do I go health wise or mental health wise? Where do I go? Okay, I'm going to go to my doctor and ask. And if we look at the training that doctors received and or the parameters of things that they can cover, it, it's kind of got a narrow track. Which
Mhm.
and if you're going in for surgery, that's great. That's all I want my
Yeah,
surgeon to do. Please,
right.
just no surgery. Know how to attach things and reattach things and remove
Mhm.
things. That's great. But when it comes to specialties that involve ongoing treatment of chronic issues or symptoms, that's where the narrow lane can be really limiting. So that was definitely my observations for sure in a lot of the circumstances and scenarios of being trained. How in the world can you be oriented to a person's life situation in 15 minutes
Right.
in meeting, every 3 months? It's not conducive to me for mental health,
Right.
for that overall specialty or aspect of our care as human beings. That's a complex aspect that requires time.
Yes. Yeah, I mean, frankly, I must say that it almost feels insulting to the entire field of psychology that there's a professional within the mental health care system that would approach working with people in that way, where it's 15-minute meetings every 3 months or so. And, that's why I really appreciate people like you who have just continued to learn, continued to study, and appreciate the complexity of factors that can contribute to any variation of human suffering or problematic thoughts, emotions, and behaviors. The one more question I had about residency, because I think it's really beneficial here for people to have a better understanding of what kind of training psychiatrists get. So the other question I had is, in light of all this emphasis on prescription as the default mode of treatment, was there training on deprescription, and how knowledgeable is a psychiatrist upon graduating about how to help people eventually discontinue drugs?
Where to start on this topic? Because that's my specialty now is deprescribing, safe deprescribing of psychiatric medications. That's all I do now. That's what my practice is full of, is patients who need help in deprescribing safely. The the education that we get in residency about safety prescribing of psychiatric medications is woefully inadequate. From what I've learned over the last almost 5 years, where I started becoming more and more aware of this topic. And what happened for me at that time is I read Dr. Robert Whitaker's book, Anatomy of an Epidemic, which I feel every psychiatrist should read. Um, that book opened my eyes to things that I had already had hunches about, and also very much affirmed some of my observations about psychiatry tending to be just very reductionistic. We are not just a bag of chemicals as a human. So if we think just applying a chemical to a human problem is going to solve it for them emotionally and psychologically, that's misguided. But after reading that book, it started to really shift my view. I honestly started listening a lot more closely to patients, and I started really believing them a lot more about what they were telling me, which in a way sounds terrible. It means I wasn't believing people before. It actually, what it means is I wasn't looking for the right things. I wasn't clearly seeing the things and identifying them for what they actually were. Psychiatric medication withdrawal symptoms are actually pretty easily identifiable when you start to see the patterns. It's not hard to notice when somebody abruptly stops the medication or reduces it by 50%, and then a week later or 4 weeks later or even 12 weeks later suddenly develops a very distinct syndrome of symptoms that are repeatable across human beings in large numbers. So the education we got in residency about deprescribing or stopping medications, for medications like antidepressants, mood stabilizers, antipsychotics even, my recollection of it is, cut it in half for 2 weeks and then stop. Or cut it in half for 2 weeks and then in half again for 2 more weeks and stop. For benzodiazepines, kind of the awareness, I think generally, and even then was, okay, we understand that if you abruptly stop a benzodiazepine that somebody's been on for a long period of time, there's risk of seizure, risk of other things, but it was still another thing. There wasn't like an exact, here's your exact book about how to deprescribe it. There were not guidelines more than, cut it in half, and time spans were usually like, a person should be able to just discontinue a medication over a month's time. When in reality, what I have now learned and seen over the last 5 years is discontinuation of any psychiatric medication that a person is taking on a daily basis can take years to get off. If someone's been taking it generally more than, I've seen people even struggle after being on it for 2 weeks. I was going to say more than 2 weeks, as a general thought about how long it can take for somebody to develop a form of physiologic dependence or struggle with coming off the medication.
If you were to just throw a ballpark estimate out on how many people you think know that risk upon starting a prescription, what
Hmm.
would you estimate?
Oh my gosh. 2%? Informed consent is where we're also really, really failing as a specialty. People are not getting conformed consent. If people knew, hey, if people had a true picture of, maybe it's going to take me 2.5 years to get off this Lexapro. Maybe it's going to take me 3 years to get off Cymbalta. They might make different choices. And then also too, that physicians aren't informed about how to safely deprescribe and what unsafe deprescribing can look like is, anywhere from very uncomfortable symptoms, insomnia, headaches, GI upset, to dangerous withdrawal symptoms. life risking, suicidal ideation, suicidal behavior when or akathisia. Um,
I
when
I'm familiar with that term, but I don't know how many people are. Can you explain what akathisia is?
akathisia is a syndrome or a set of symptoms that can include a feeling of inner restlessness, which can manifest outwardly as a feeling of a need to move. So people describe it as like they feel like a motor is running inside of them. They need to move. So what I've seen an extreme expression of that is pacing, circling the house for hours at a time, hours. And I've heard of somebody pacing 20 hours a day. It also can manifest as a feeling of inner terror, inner abject, like the worst terror you could ever possibly imagine, that is unrelenting, unremitting, throughout the day. And it's commonly a side effect of it can be a side effect of a medication. It can also be a withdrawal effect or a withdrawal symptom of a medication. And I've seen it across, I think, all medication classes as a potential withdrawal side effect.
Wow.
Yeah.
So, thank you for explaining all of that. And that was all, stemming from me asking you, like, what education did you get in residency about deprescribing? So I have more questions about that, but I wanted to continue tracing your professional journey a bit. And so you complete your residency, you graduate, you're a licensed psychiatrist or board certified psychiatrist, and then you know, for how many years are you practicing conventional psychiatry?
After residency,
Yes.
0.
0. Okay.
Conventionally, no. I mean, mm, I didn't feel comfortable with it. I mean, to be honest, I didn't feel like it was ethical.
Mm,
It didn't align with me as a person. So I started my own private practice after residency. I saw people mostly for therapy. Here and there, medications would, if they were involved, they were minimal, very minimal. I was always trying to show other modalities, other ways, in trying to take a holistic approach to things from the get-go. I didn't, um I take that back. There was a brief stint. I think I did 3 or 4 months, back during COVID is in traditional, and then that was, yeah, just a brief blip of trying to practice traditionally.
mm. And so it's been about 5 years now that you've had this holistic approach. Is that correct?
5 years where I've specialized, I would say, in deprescribing,
Mm,
using a holistic approach,
mhm,
because deprescribing is not just about, what I've learned over time through experience is it's not just about mapping out a schedule, like, here's your Excel spreadsheet and here's your deep, here's your I'm sorry, hyperbolic tapering dose schedule. Okay, go. It's a lot deeper than that. It is the human's experience of when we're working with brain chemistry, and psychiatric medications alter one's brain chemistry. Sometimes I think that people don't even think about that somehow when they first start them or are on them, is we're working with brain chemistry, which is a highly sensitive aspect of
yeah,
our humanness. Um, and so when people are working through a tapering path, they need support. And or it really is helpful for us to look at all the things that affect human mental health and physical health too. I mean, they're interwoven, very
mhm,
deeply intertwined. So it's very helpful to take a holistic approach to that. So we talk about all the things. diet, nutrition, supplements, exercise, stress levels, relationships, your spirituality, all of your general life situation and circumstance, your fulfillment in life, presently.
Mm.
With people that I work with, I wanna know their whole life as much as I can within the, time constraints we have. I wanna know what's going on because it matters as we're working with deprescribing a mind-altering substance.
Yeah.
So it's complex.
Yeah.
People
Yeah.
need support. You need to be with them and helping them understand, and people will come knowing they wanna get off and knowing that they have that goal. And then the journey that it takes to get there, it's complex. There was an original distress for everybody. There was a reason. There was a reason the medication got started. There was an original distress. We have to talk about that, look at that, what was going on there, what was the situation, circumstances, symptoms around that, where are they now, it's it's a it's a big deal. It's not just, it's certainly not a cut it in half for a couple of weeks and a half again and stop.
Right.
It's oftentimes, most often, um, a multi-year experience for people. And the goal for me is with a lot of times people will come destabilized because of the unfortunate advising that they got about abrupt reductions. They'll be destabilized, having severe withdrawal symptoms, so also helping them with stabilization, and then working with them to hopefully create any kind of withdrawal symptom experience into nuisance level symptoms rather than derailing people. I mean, people losing relationships over withdrawal symptoms, jobs, not being able to function in their day-to-day lives, which could be prevented if physicians had the right education about what to do.
Right. One of the things that the topic of deprescribing makes me think about is all the people I've gotten to know really well, and some long-time listeners of the podcast have heard me talk about the work I get to do in jails and prisons. I'm part of the movement of bringing higher education into jails and prisons, which ultimately translates to me having this very special opportunity to get to know people doing time in jail. And they share, they're very, very open with me. And they talk about their drug abuse, they talk about their experiences in their lives in general and within the jail. And they talk to me very openly about their experience with the psychiatrist in the jail and the drugs that they're being prescribed while they're in there. So there's a lot I can share about that. But the one thing I was going to say is I noticed that many of the people I work with are in there on drug charges. And so they have pretty severe drug addictions, most commonly to methamphetamine or alcohol or heroin and sometimes cocaine. And first of all, many of them realize that there is a legal prescription equivalent of their favorite street drug. Meth addicts like Adderall, and heroin addicts like sedatives like Seroquel. And so sometimes they're able to get that drug prescribed to them and essentially satisfy their chemical dependency, which is its own set of problems and its own way of being counterproductive to the rehabilitation process. But for the people who don't realize that or don't end up getting that prescription, the attitude toward them when they're locked up is to just get through with your withdrawal symptoms. I'm sure people have a sense, and you probably know very well that heroin in particular has very intense withdrawal symptoms, diarrhea, pain throughout the body, restlessness. People talk about getting the kicks where they can't, like they have to kick their legs because they're so restless. And it's just absolutely miserable. But what's interesting is both kind of the general view of that, as well as the way they're treated by law enforcement, by the judge, by mental health staff, is just essentially, well, you get through it, drug addict. This is the price you pay for abusing drugs. And so get through it. And there's just no sympathy or compassion for that. And there's definitely no strategy for like minimizing the dose or anything like that, right? Because these are illicit substances. So what do you think about that? Like, do you think there are maybe that there's a way to de-prescribe, so to speak, or slow down the use of street drugs? Or also, are there people who might be like needing to, I almost hate to put it this way, but take a page out of the book of people who are incarcerated, getting through their withdrawal symptoms and just like grind their teeth and get through it. I'm curious your perspective on these issues.
I think that's amazing work that you're doing, by the
Thank
way.
you.
Super incredible.
Thank you.
Yeah, I rotated through a prison during residency, and I admire and appreciate anybody who's willing to look out for the rights of those who are incarcerated. A very vulnerable population, for sure. My thoughts are about it is, first and foremost, to be humane to any human. I don't care where on earth you are. Let's be humane first. And to me, when it comes to any mind-altering substance that the body has developed a physiological dependence on, when you try to reduce that or take that away, the brain is going to react. The body is going to react, and it will produce symptoms that are horrific. I mean, I have numerous times heard people describe this as, I mean, it's uncanny how people describe it repeatedly across people who don't know each other from around the country, that the withdrawal symptoms are the worst experience of their lives. Horrific, torture, hell, unimaginable. I wouldn't wish this on my worst enemy. It is a form of hell that I did not know existed. Because partially too, you can't see it from the outside. If somebody has a broken leg, we can see it. Or something going on physically, we can typically see it. With the brain, it's internal torture. It's internal chemically induced torture. So do I think that they should also taper illicit drugs for a person? Absolutely. Especially when you have such a controlled environment. Should that be, an addiction specialist would know this way better than me, for sure. Because I know there's other, things that they use to abate things, and Suboxone and things like that, But yeah, from what I understand of how horrific withdrawal can be, avoiding that, doing whatever we humanly possibly can to avoid that for someone, absolutely, that's humane, I think. And interestingly, I've heard from people who've tried going to rehab centers, like residential or inpatient rehab centers, to come off like a benzodiazepine, come off Klonopin. And the technique so far that I've heard, and maybe there's other ones out there that do it, but they will cold turkey people immediately and then provide other medications for symptoms that come. Which is terrorizing for people, for what they go through, because the other medications that are applied to help reduce the physical symptoms don't reduce the mental symptoms of what people go through, when the abject terror, the extreme anxiety, the just horrible feeling that people describe in withdrawal. And I would sometimes wonder too, because their length of stay has to be short. People stay for like a month or two, where benzotapers take years, easily. coming off a milligram of Klonopin can easily take a year. If not, probably more aptly 2, depending on the individual, depending on the circumstance, depending on that particular person's, whole system versus, being taken off in a day. So we have a lot to go when it comes to educating and having understanding and compassion for the process of coming off a mind-altering substance.
Yeah. Well said. Agreed. And part of that journey toward minimizing this torture is just not prescribing them so much in the first place. And I know it's obvious that I think that, but I just want to state that very clearly.
Mm.
Um, like a message to anyone who is in the practice of prescribing, like, chill, bro. Be careful. Stop doing this so much. What are you doing? Like, this is not okay. And my passion and my indignation is growing stronger, through the years. You're one of many guests that we've talked to on this podcast about this topic, and I've been steeped in this research ever since I was doing my whole PhD program. And what I witness in the jails is just the most, what would be the right word? Just careless, the most careless prescription practices imaginable. People there's jails where I work at where since COVID, the psychiatrists, they don't even really step foot into the facility anymore. And they're just meeting with people through Zoom for about 5 minutes, is what I'm told, every month or so. And there's just zero effort to get to know the individual. And there's just, again, careless prescription practices, adding drugs on top of other drugs, increasing doses, just so cavalierly. So I just needed to say that. But I also want to ask you, when people are like, what would you say to a person who's listening, who's currently taking a prescription psychiatric drug, and they hear you saying what everyone is saying, that this withdrawal process it can be torturous, it's so hard. What would you say to the person who thinks to themselves, maybe I'll just stay on this then?
Mm,
What is the motivation to come off of it then, if it's so difficult?
that's a great question. And I'll preface it by saying too, just to kind of back up, is I also I don't want to be an alarmist either. If especially people listening who are on medication, is some people can get off these medications just fine. That's great. And there are a significant number of people who can't, just stop it and be fine. Staying on it as the easier path, with the right info, you just need a little bit of the right information. With the right education and information, coming off a psychiatric medication can be, like I said, nuisance level kind of effect in your life. You just have to have the right information about how to do so. So having support from a knowledge, ideally, although I think it's extraordinarily impossibly rare to find a provider who's truly knowledgeable about safe deprescribing with the aim of the person being able to make it off the medication for good. The risks of staying on, certainly it depends by class of the medication, but maybe just more globally or generally looking at it, the medications themselves are designed to disrupt our biochemistry, and they're all highly effective at numbing. all of them. It's not like the SSRIs or the antidepressants just go in there and just numb depression
Right.
or benzos. Just go in there and numb anxiety, the anxiety little part of your brain. That's not how it works. It's a global numbing effect. So people's experience of being on them, I just had someone just a couple of weeks ago who is experiencing some withdrawal symptoms and is now off her medication, who is describing her observation of its effect on her and over the time of tapering, the things that have come back to her. Feelings of love and care for her family members,
Mhm.
feelings of interest in things, feelings of engagement with life, is observing her mother, who's also still on psych meds, is not going to come off of them. And she wonders now, too, about how much her relationship with her mom is impacted by the nature of the numbing effect of these medications. So, this is where I wish we would all just collectively pause and reflect on that as a community, a health, the healthcare community, because it's actually 60% of psych meds are prescribed by general practitioners.
Right.
They're started by GPs. So we're only, even us, we're only the 40%.
Mhm.
Let's collectively pause and reflect on the fact that we are giving chemicals to people that are altering their lives, their relationships. Would you want a chemical that's potentially impacting your relationship with your dearest people? Your mom, your kids, your partner? These are not, and I hope it gets there at some point. In my optimism and hope, I feel like at some point, I hope it gets to the point where we look at psychiatric medications as absolute last resort. When you have tried everything else under the sun, not a first line intervention. And don't get me wrong, I am not anti-psychiatry in totality. There are moments or points when a psychiatric medication is the safest thing we have for somebody, potentially, or is going to be something that keeps a person here on the planet. Um, the other, the other vast majority of it being prescribed for me is how many of those other people tried all the other last resort things before resorting to a mind altering
Right.
substance. So that's what I would say. And I don't want to instill fear in people who are on them. If you're on them, you know, it's fortunately very easy to start doing some research.
Mhm.
Talk to your provider, talk to them. The Maudsley Deprescribing Guidelines is a great resource to start to help the understanding be out there about how to taper, that there's a safer way, that even tapering is even a thing that people can do, that reducing a medication more gently, 5 to 10% at a time is not, that's actually a helpful approach to
Mhm.
deprescribing.
Mhm. Have you seen the movie by Pixar, Inside Out?
Yeah. Yeah.
And then people know that there is an Inside Out 2 now. And in my, as I'm always trying to find fun ways to teach certain topics, and when I talk about emotions in my different college classes, we'll often watch little clips from the movie Inside Out. And you may remember a part where they depict sadness as basically being banished into the unconscious of this little girl's mind. But when sadness goes, joy has to go with her. And so there's this whole part of the movie where sadness and joy are in the unconscious. And then in like the second movie, I think they depict that with like all the emotions: fear, disgust, joy, sadness. They're all in the unconscious. And I just think what you said just now is very powerful, that although, whether we're talking about prescribed or illicit drugs, just generally speaking, although mind altering substances can succeed in numbing pain, like you pointed out, they don't just numb pain, they numb emotions in general. And so perhaps that could be the greatest motivator for safely stopping a mind altering substance is the access you'll gain to higher heights of joy and more intense feelings of love and connection. And with that, we can all be realistic. With that will come stronger, painful feelings as well. But I mean, what are we talking about here? Do we expect something different from being human? Do we expect, like, grief is the other side of love? And there's so many painful emotions are not just natural, but actually crucial when we're directing our lives and attempting to navigate relationships and live authentically and respond adaptively to our environments. And I recognize that sometimes the pain is just too great. And I am not against some type of chemical intervention as a last resort. I recognize the value of that. And you may disagree with what I'm about to say, but um, I don't see it as all that different when a person uses alcohol to, like, um, you know, mitigate their social anxiety. I don't see that as being all that different from a person taking some type of benzodiazepine to mitigate their anxiety. And I sometimes wonder if some of these natural substances that people are drawn to, like alcohol or even cannabis, um, might actually not complicate things as much in their life. I mean, obviously, alcohol can have some very severe withdrawal effects, even including death. But other substances, we had a guest on here named David Cohen, who is a professor at UCLA, and that was one of our big focuses in our conversation was the illusory divide between illicit and prescribed drugs, and how maybe on that side of the wall where we call these drugs illicit, it's kind of the same mechanism of action, and maybe some of them actually don't cause the same extreme dependencies. So I'm not, to be clear, advocating that anyone smoke or drink their worries away, but I am acknowledging that when we're talking about mind altering substances, let's talk about all of them, especially the ones that people have been using for much longer than psychiatric drugs have been around. But the bigger point is just to emphasize what you said, that if sadness is banished into the unconscious, so is joy.
Yeah. And I think if we reflect on that, like, if we really reflect on what are we doing as a population, the thing about it is, I think healthcare has become such an industry and maybe part of the evolution of a society and, a capitalistic society with a lot of wealth and a lot of systems and the systemization of medicine, it dehumanizes it. Any system dehumanizes. And when you dehumanize healthcare, it gets scary because it's lives. I think nobody loves the idea of their, elderly grandmother going through a system. They want to
Right.
think of them as cared for and, thought about and compassion and empathy and care and concern. But the more we speed up, the more we systematize, and there's a lot of structure in place to reinforce that, you know, the less we'll be able to include the complexities of what we are as human creatures. And it's the healthcare delivery, which is then, reinforced by the financial piece, the insurance systems, third party payers. The whole system is kind of set up to drive output or throughput. That's what I felt like in residency. I felt
Mhm.
like how you're scheduled, 15-minute appointments, um, intakes of 45 minutes or maybe an hour, which and not without the emphasis of like, this is a human person. you need to know their story. You need to really get to know them. There needs to be a certain amount of mutual trust, respect, and intimacy in a relationship where you're going to talk about and deal with brain chemistry and their psyche. And we've tried to societally, and it's going to be just human nature to go to a quick fix. That we just all kind of share that as a human trait or foible or whatever.
Mm-hmm.
We want a quick fix, and the system just really reinforces that. And mental health is not a quick fix. It's just not. I mean, yeah, it's
Right.
not an efficiency-based thing. It's you need to give some space and time. And what's fascinating to have watched evolve just myself out of this whole thing of establishing a deprescribing practice is to see that people will show up for that. Patients will invest in that out of their own pockets. As a provider, you can afford a mortgage, like to find out that the exchange of, resources that's involved in that is life sustainable for both of you,
That makes
both
sense.
both parties involved.
Mm.
So it gets more kind of, some people may feel like it gets more esoteric or existential, but I personally don't. I feel like that's just very practical to actually treat humans as humans and to take the time and effort to help people.
That's a
And
great
I
point.
don't know why we don't have a task force looking at why in the world are 1 in 6 of us on psych meds.
Rats.
That is not good for us as a nation.
And
It's not good for us as a human population. 1 in 6 of us, because really probably a more realistic number for those who probably truly may need it. Maybe there's something biologically, organically going on where maybe the best thing we have is a medication's probably more like 2 or 3%. I would guesstimate, just as my experience as a psychiatrist,
yeah,
working with people, observing across all the different diagnoses, maybe 2 or 3% of us need it. So, and certainly if we're going to use them, understanding that their implications, and just what are we, I mean, it just opens up a whole Pandora's box of questioning, what are we doing to ourselves as a culture and society if 1 in 6 of us are numbed to our human experience, to our feelings, to our emotions? It changes the thoughts we think. It's very clear, like when you ask somebody, like if you ask somebody to think of what does somebody who's drank 10 beers look like, and how
mm,
it's very clear
mm,
that there's a substance impacting their behavior, their everything, their expression, their humanness. When we're taking a psychiatric medication, we are altering our behavior, our thoughts, our feelings, and our humanness. So kind of, we're influencing brain chemistry.
yes,
And when we have stepped into that realm, I just feel like we've just kind of very kind of casually crossed that. I think you were saying about, your observation of the prescribing. Just we treat it so casually, flippantly,
yeah.
as if altering brain chemistry isn't the hugest deal of your life. And 7 million children on psych meds now, and that's only growing. And almost maybe there could be some sense gleaned if we saw like our happiness levels were just off the charts.
Mhm.
Our children's well-being was just off the charts. Suicide levels, if they were dropping, if the
Yeah,
incidence and presence of social violence was diminishing, if the incidence and presence of depression, anxiety in the culture was diminishing. Well, I'd be like, okay, well, whatever we're doing's working. It's not that.
right.
It's
Quite
the
the
opposite of
opposite.
that.
Yeah.
It's quite the opposite. So we have to ask ourselves collectively, I'm there's this, those of us here on the fringe kind of asking the questions, doing the research on our own, trying to figure it all out on our own. we're the one-offs. When is the conversation gonna coalesce more? And it really is actually, though, if you follow it, what's happening because of the advent of the internet, thank goodness, the voices collectively coming together. The thing about humans is if we can't find answers one place, we will start trying to find answers in other places and or to relieve our pain and suffering. We will do that. And that's what's happening via the internet. People are collecting, people are gathering there through Facebook groups, online forums, online peer-based support communities. And they're tens of thousands of members strong. Cymbalta Hertz is, I think, 40,000 members. That's a group that's trying to just help each other, people trying to help each other through the bewildering, terrifying, disruptive experience of withdrawal. So my thought would be, we shouldn't be doing that. Why is it that their best resource for information, help, support, and guidance isn't the person who prescribed it? So we are way off. We are way off right now as a medical culture about that. We are way off. I kind of describe it to people as like we're in an information gap. We are right now living in a almost surreal feeling information gap where physicians do not have the education to be able to give good information. I know how physicians are trained. I was trained that way. I said the same things. I operated under the same kind of guises, that physicians do about psych meds. And it's off. And it's hurting people. And that's where I just feel that it's sad. I mean, it's a shame. But again, I would say the collective human voices are crescendoing. We figured out that thalidomide was not a good idea. We figured out lobotomies were not a good idea. We figured out opiates. I sincerely believe or hope that the same kind of crescendo of voices and then subsequent understanding about what we're dealing with when it comes to psych meds will happen. How soon, how quickly, let's see. There's been people who've been spearheading this movement for 20 years. Robert Whitaker's book's like 20 years old. And others, you got Joanna Moncrief on here, and Adele Framer. There's,
Peter
Margaret
Breggins
Lewis.
and
Peter,
OG. Yeah.
I think he's 89,
Yeah.
and he was saying this, but it's a big ship, and it's complicated, and big ships don't turn fast,
Rats.
but they do eventually turn.
I'm
So
so glad everything you said was recorded and is now on the internet because you nailed it. Yeah, and I think that does instill hope. But we have to be persistent, I think, and I guess keep talking about it, and keep platforming people like you and joining forces. Somehow we've been talking for almost an hour here, which is kind of amazing to me. But I want to make sure people know where to find you. So talk to us about your private practice. What's it called? Where can people connect with you?
So my private practice is True You Psychiatry and Wellness. You can find me at www.trueyouspsych.com. Happy to hear from you. Give us a call or an email. All our info is out there. And yeah, I'm licensed in 7 states.
Okay.
So California, New York, Florida, Michigan, Georgia, Arizona, and Virginia.
I can't thank you enough and just honor you enough for the noble work you're doing. I just admire it so much. As I said in the beginning of this conversation, to witness a person question the paradigms that they were being, um, kind of initiated into, through a kind of, I think, an element of the dynamic we were talking about earlier about like why medical students or residents don't question things. In my assessment, is that there's a degree of the status um, spell where you're in what society considers to be one of the most high status professions. And who would ever want to jeopardize that? Who would ever want to be an outcast to the most high status group that you've worked so hard to become a part of? And so for you to do that and to go your own way and to, like I said, question everything that you learned and trust your own intuition is extremely admirable. And I am so grateful for people like you.
Thank you so much, and thank you so much for what you're doing to try to raise awareness. I appreciate seeing that out there for sure. That means a lot, and that's how it happens.
Mm,
That's how lives get changed and touched, is the more and more good information that people have. That's the thing that makes all the difference. So, thank you for your appreciation, and I appreciate it right back.
cool. Well, I'm very glad we are connected. I trust we'll stay connected. And I am always, meeting people and be there face to face or hearing from them online who are ready to de-prescribe, who are ready to taper off and, break the dependency of their psychoactive substance. So you may get some referrals from me. That's for
Thank you
sure.
so much. I appreciate
Yeah.
that. I appreciate it.
Well, Dr. Jennifer Giordano, thank you for your time today. And I'm sure everyone who's still listening now gleaned great value from this conversation.
Thank you so much.
Yeah, and thank you to the listeners. I always want to give a big shout out at the end of the conversation, these long form podcasts, the people who are listening to the whole thing, it's like this is really for you. So I'm so glad that those of you who are still listening, that this kept your attention and was relevant to listen to. So much love from Psychology Is and Dr. Giordano. I will talk to you again soon.
Thank you so much.
You're welcome.